Good morning. It's my pleasure today to introduce Dr. Rebecca Rogers. Rebecca Rogers actually began her career as a math teacher in the Peace Corps in Swaziland, Africa. And from there, she trained in experiential learning as an assistant instructor for Outward Bound. Rogers received her medical degree from Harvard University and completed her residency in obstetrics and gynecology and also a fellowship in female pelvic medicine and reconstructive surgery at the University of New Mexico. After her training, Rogers joined the faculty at University of New Mexico, where she established their urogynecology fellowship and also started within the division of urogynecology. She also continued to work internationally and performed vesicovaginal fistula repairs in Liberia and Benin. She now works at the University of Texas at Austin Medical School. She's been funded through the Eunice Kennedy Shriver NICHD with a U10 Center grant, and also has had R1s. She's authored over 140 peer-reviewed publications, 4 books, several book chapters, and makes instructional videos, and is also an advisor to our own Dr. Heidi Brown. Today she's here to talk to us about perineal outcomes following birth. So maybe I'll welcome.
Thank you very much. Everybody can hear me? Usually that's not a problem, hearing me. Thank you for your kind words. That's very sweet of you. I have another tie to the University of Wisconsin because Dr. Sarda was my chair, gave me my first job because I couldn't find a job anywhere else. Thank God she hired me. And my program director. So there you go. Things always come full circle. So I'm going to spend a little bit of time today talking about perineal outcomes. I think many of you will be familiar with this already, but hopefully we'll learn something new. I do have 2 disclosures. I receive royalties from UpToDate for chapters that I've written for them, and then I do receive travel and stipend from ACOG, the American Board of OBGYN, and the International Urogynecological Association. So our objectives today are to describe the incidence and risks of severe perineal laceration and resultant pelvic floor dysfunction following vaginal birth, and to describe some prevention strategies. So the perineum is ours, right? Nobody else in the medical field spends as much time looking at it, rubbing it, touching it, repairing it, wondering at it. So this is ours. The colorectal surgeons don't know this area. The general surgeons try to stay as far away from it as they can. So this is ours, and we need to be the experts taking care of these problems. So we all know that birth affects the pelvic floor, right? How could it not? It's not possible that birth does not affect the pelvic floor. That doesn't mean that it shouldn't affect the pelvic floor, right? It just does. So our jobs as obstetrician gynecologists are to understand those problems and also the normalcy of its effects on the pelvic floor. And when things go awry, address those problems. So let's talk about lacerations. Has everybody in the audience seen a perineal laceration? Has anybody not seen a perineal laceration? So we're familiar with this, right? So almost everybody sustains some kind of perineal laceration at birth. Mostly, they're not very significant or important or problematic for the patient. Now, we tend to focus just on the posterior perineum, right, between the vagina and the anus, and look at those as perineal lacerations. But lots of lacerations happen outside of that area, right? So periclitoral, perilabial, etc. Those count, right? If you're the person, those count as lacerations. So I think that we have missed an opportunity to understand how those other lacerations affect women, and there's something that we could pay better attention to. Now, factors affecting trauma. So there's going to be a theme here throughout the talk about the 2 biggest factors that affect perineal trauma. What do you think they are? Episiotomy and forceps and vacuum. Operative vaginal delivery. Those are the 2 things that affect the pelvic floor the most. Now, what is your rate of episiotomy here at the University of Wisconsin? How many of the residents have never cut an episiotomy? So episiotomy, the word is out on episiotomy that it is a procedure that has been found not to cause harm but not offer benefit. And so most academic institutions have really gotten away from it. Does that mean that you should never cut an episiotomy? No, it does not mean that, right? But it means that low levels of episiotomy. When I left the University of New Mexico, I think that our episiotomy rate was about 1 or 2%. It's very, very low. In most places in Europe, and what the exact rate of episiotomy is, I don't think anybody knows. In most places in Europe, it's much, much higher, and I'll show you some literature that looks like that. Forceps and vacuum. So we're going to talk a little bit more about that as we go through. So right now, and when I started my career, the incidence of episiotomy was about 1 in 4, right? So it's about 1 in 10 now, much, much lower, but that is the mean, right? So there's lots of variation. If you're at 1%, it means that somebody's still at probably 1 in 4, right? So don't be surprised when you go to wherever you're going to be employed and geez, you know, the episiotomy rate's a lot higher. So it varies with provider, practice, where you live, and what time of day you happen to have your baby. I'm not sure exactly why that is. Maybe when it's dark, it's harder to cut an episiotomy. I don't know. So let's talk a little bit more about episiotomies. There are 12 randomized trials with 6,100 women. And these trials, now remember, when you randomize physicians, they don't always do what you want them to do, right? So it was no episiotomy or episiotomy, but in actuality, the allocation was 8 versus 59%. So it's not 0 versus 100%. Many trials used a medial lateral in this review. It had equal healing, pain, sexual function, or incontinence. So the conclusion was not that it caused harm, but it didn't add benefit. So to do a procedure that doesn't add benefit, and potentially in some other studies causes harm, I think this was a landmark paper by Dr. Hartman. So in terms of the episiotomies that are cut here, are they midline or are they medial lateral? So how many people have been cutting medial lateral episiotomies? No. So this would be quite different in the rest of the world. Again, I'm going to show you some more literature. So why don't we cut medial lateral episiotomies if we need to cut an episiotomy? They hurt. Well, all episiotomies hurt, right? But they hurt. Okay, what else? Harder to repair. Bleed more. Bleed more. So I will challenge this audience to find the literature that supports that. It is a myth in the United States. The entire rest of the world cuts medial laterals. The entire rest of the world. And the literature would not support that they cause more pain. It would not support that they're more difficult to repair, and they would not support that they bleed more. So this is like we believe other things in medicine that just aren't supported. So I think I know this literature pretty well, and I haven't been able to find something that supports that. So now let's talk a little bit about classification. So an amazing thing happened between when I was Dr. Sardo's resident and now is that women grew an internal anal sphincter. They didn't have them in the early 1990s. It didn't exist, right? So when we repaired 3rd or 4th degree lacerations, and we had a lot of them because I did about 250 forceps deliveries in my training. A lot of 3rd and 4th. We just repaired the external anal sphincter. So this new categorization, which is supported by ACOG, includes 1st degree, 2nd degree, 3rd degree, which includes what's going on with the internal anal sphincter. Now the internal anal sphincter, we'll talk about that in a minute, is what's keeping us continent right this second, right? It's working, we're not thinking about it, it's nice and tight, and it keeps us continent in moment to moment. So this grading system with how much of the external anal sphincter is affected also includes, if you don't go through the rectal mucosa but go through the internal sphincter, that's a bigger deal than if you just affect a part of the external anal sphincter. So there are people that can link this to outcomes. And the ACOG Revitalize is promoting this categorization. It also states that if you're not sure, upgrade, okay? So instead of giving yourself a break, well, I don't really think it's a third. No, you should upgrade, right? If you have a question, you should upgrade. How do we repair second-degree laceration? So we know there's lots of literature that synthetic suture is better than chromic. Is anybody still using chromic here? Right, that's good. Less pain, may require removal of the sutures. Probably continuous sutures are better than interrupted, and do not suture the skin. So the nerve endings of the skin are about 3 millimeters below the surface. So when you suture that area, people have more pain. And patients that did not have the skin sutures said it felt more normal. So the minute the woman puts her legs together, those edges will come together. So in terms of second-degree lacerations, the randomized trials would support Vicryl or Vicryl Rapide, and a delayed absorbable of some kind for external anal sphincter, and I'll talk a little bit more about that. Now this is a little bit more controversial. Do y'all repair all second degrees? If you have a second degree, you're going to get sutured. Okay. So there are people who do not repair second-degree lacerations. And there's been a number of trials. These are two. One is a randomized trial. It was small. And they found no difference in suturing versus not suturing these. They did find that repair negatively impacted breastfeeding and getting the baby on mom's skin. So there may be some negative. We did a cohort study at the University of New Mexico, and we compared women who had their second degree sutured versus unsutured, and to women who delivered with an intact perineum. So of course, those with an intact perineum did the best. They used fewer pain medications, had lower pain scores. But all of the longer outcomes were not different between the three groups, including pain, sexual function, urinary or anal incontinence, perineal measurements at 3 months. Not different if we did not suture second-degree lacerations. So again, not everybody in the world sutures second-degree lacerations. In midwifery practice, it's quite common not to suture second-degree lacerations. Okay. Now, anal sphincter lacerations. So these are severe lacerations. And an anal sphincter laceration, what if it only goes a quarter of the way through the external anal sphincter? Is that an anal sphincter laceration? Yes. Okay. So it's really hard to get at the incidence of anal sphincter lacerations. And this was actually a proposed quality measure. So what happened when anal sphincter laceration became a quality measure in most delivery wards? What happened to the incidence? Went way down, right? Because when we start measuring, we like to give ourselves a break, right? So it has been removed because it really undermined our ability to know what the incidence is. But it's probably somewhere around 3%. It may be a little bit higher. The systematic review will be in studies that are specifically, looking for those lacerations. So I think about 3% is what you're going to see in most reviews. Now, what are the risk factors for anal sphincter laceration? So, what were our two biggest risk factors? Forceps, episiotomy. So, odds ratio, 5 times. Vacuum-assisted delivery is less. Midline episiotomy increased fetal weight, and other factors include things that we would normally think of, primiparity. Asian ethnicity will come up over and over again, and the reason that is that the perineal body in many Asian women is smaller, so they're at higher risk. And persistent occiput posterior position. So none of this is really surprising. This is a huge number of women, and these probably really are the risk factors. These are things you should be thinking about in the delivery ward. So, what about the difference between forceps and vacuum? How many of the residents have done a forceps delivery? Quite a few, okay? Many places I go to, none of the residents have done a forceps delivery, right? And forceps are becoming less and less frequently used. And the reason that is that if you look at the randomized trials, and I was trained with forceps. I think I could still put on forceps, but if you look at the randomized trial of looking at vacuum versus forceps, you have an increased incidence of anal sphincter trauma. You can't deny that. You also have, and I'll show you some literature, an increased incidence of damage to the levator ani. Most of the studies showed no difference in the ability to get the baby out. There is an increased incidence of cephalohematoma, as we all know, with vacuum delivery. But this, I believe, is something that we should discuss with the patient, right? This is going to cause more trauma. You may have a cephalohematoma. This needs to be a shared decision because there are long-term sequelae to using forceps. There are places in the U.S. that are still doing a lot of forceps delivery, but it is the minority. Most places are not doing that. So let's talk a little bit about anatomy. So the external anal sphincter is made up of striated muscle. It extends for 2 centimeters up the anal canal. It lies in close proximity to the puborectalis. It's responsible for the squeeze tone and 10 to 20% of the resting tone of the anal sphincter. The internal anal sphincter, this clever little muscle that has evolved in the past 20 years, is 3 centimeters. It's smooth muscle, continuous with the colon, and it's responsible for the resting tone. So everybody cough. Cough on. All right. Every external sphincter in the room just contracted, which is great because that kept us continent with sudden increases in pressure. And our internal sphincter is just chugging along, doing its job right now, thankfully, while I'm talking. Now, the other thing that we want to talk about are the endovascular rectal cushions. What the heck are these? These are the blood vessels that encircle the anal canal. It prevents seepage and does contribute to the resting pressure of the anal sphincter complex. 10 to 20% of the anal sphincter complex. What's the other name for these things? Hemorrhoids. So women who have hemorrhoidectomies are at increased risk for fecal incontinence, and we don't see this too uncommonly. So here you can see, I'm trying to, here. So here we can see the external, that's really weird. You can see the external anal sphincter, the internal anal sphincter, and the hemorrhoidal tissue. So this complex extends for 3 to 4 centimeters up the anal canal. So everybody pick up their index finger and look at it. If you're repairing, the back of the room is just not very participatory. Come on. If you're repairing something the size of your index finger, is your index finger 3 to 4 centimeters in width? Is it? Well, it depends if it's a GYN 4 centimeters or an obstetrical 4 centimeters. Those are 2 different measurements, right? So if you're preparing something the size of your pinky or your index finger, you are not repairing the entire complex, right? It extends for a distance up the anal canal. All right, so let's talk about how we repair this. First, this is a cadaver, so see, no leg, no blood. So it's a cadaver. And there's a very funny story about this cadaver, but I'm not going to share it. So we got locked in a tunnel with this pelvis for like 7 hours. It was terrible. Anyway, so you repair the rectal mucosa with a fine, delayed absorbable suture. It doesn't matter if you go through and through the rectal mucosa. What really matters is to just close it, okay? So if you do go into the rectal mucosa, I wouldn't pull it out. It probably will cause more trauma. The tissue's already very traumatized, usually in these situations. So the important thing is to take large bites. Next is the internal anal sphincter. Now, I've heard lots of people say that they are able to close the internal sphincter when they're closing the rectal mucosa, right? So they just take a little bit wider bite and they somehow get the internal sphincter. No, you do not, right? The internal sphincter, we said, was made up of smooth muscle. What happens to smooth muscle when you cut it? It retracts. All right, so you're going to have to go after it, right? You're going to have to bring it to the midline. And I like to close this with an interrupted suture just because it's hard to get those two ends together. It's often retracted. It's this white, shiny tissue that's lateral. One way to find it is to put your finger in the rectum and feel laterally and see if the anus moves. Now, lots of debate over how to repair the external anal sphincter. This was a raging debate when I was a fellow, whether we put it end to end or whether we do an overlapping repair. Our colorectal surgery colleagues were doing overlapping repairs for delayed sphincterplasty. So a woman presents in her 50s or 60s with anal incontinence, and they might do that surgery. So, of course, unfortunately, as OBGYNs, we often defer to our surgical colleagues as being more expert. But what did we start this talk with? Who knows this area best? We do. They don't know this area. They maybe do one sphincterplasty in their lives, right? So we know this area, and we're going to have to take care of the patient afterwards. So if there are some randomized trials looking at anal sphincter repair, the first trial was done out of Abdul Sultan's group in England, and they randomized women to either Vicryl or PDS, very delayed absorbable, overlapping to end. So it was a factorial design. They had 4 different groups, and they really didn't see any differences in the repair method at 6 weeks to 1 year. They did have poor follow-up in that trial. Fernando, also out of Sultan's group, randomized to end-to-end or overlap, and overlap was better. And the meta-analysis in the Cochrane database says that overlap may be slightly better, but the data are limited. So, let's put this in some practical context. If you have a partial third-degree laceration, what repair method should you use? End-to-end, right? For God's sake, don't cut the rest of the sphincter, okay? Don't do that, right? So that's an end-to-end. So that one's easy. Now, if you're all the way through the sphincter, I think that because the difference in outcomes is very minor, you should do what you're most comfortable with. And the really unfortunate thing about all this repair data is that, unfortunately, let me go back. Unfortunately, our outcomes are not very good. So let's look at that. If you look at studies that took women who had anal sphincter lacerations and then followed them with an ultrasound to see if the sphincter was still intact, we don't do very well. Why is that? That's because as soon as the patient wakes up, those sphincters start pulling apart. And up to half of them are just going to not be together when we go back. Now, that's not an argument not to repair. It is an argument that if someone presents much later, let's say 10, 15 years later, with anal incontinence, this is why we've really gotten away from sphincterplasty. Because the success rate for sphincterplasty at 10 years is 0 to 10%. 0 to 10% cure, right? So again, I'm not saying we should, please do not go out in this talk and say, well, Dr. Rogers said we don't have to repair a 3rd or 4th degree, because that would be bad. Let's not do that. On the other hand, we need to know that if a patient, this often happens, a patient delivers somewhere else, comes in with a problem, and you'll say, oh, it was unrepaired. Well, you weren't there. You don't know whether it was repaired or not. It may have fallen apart. It may not, you just don't know. So these things do fall apart, unfortunately. Now, do we miss sphincter lacerations? What do you think? It's 2 o'clock in the morning. It's been a long time pushing, a primipparous. You have 4 other people on the board. You're tired. You guys never get tired, right? Yeah. And there's a laceration. Do you think we could miss a 3rd or 4th? Why do you think that is? It's dark. Birth is messy. Right? You got other things to do. So indeed we do. We thought at first that we were missing lacerations that were hidden under the skin, right? They were called lacerations. But there's been a couple of studies that have put a second observer in the delivery room. So if you have a significant laceration, what they did is they brought somebody in to do a second look, and it increased the detection rate by about 40%. So this has been substantiated in other trials. I think the learning point here is that if you're not sure, or if you have a deep laceration, have somebody else take a look, right? I personally think that if you have a 2nd degree laceration, it warrants doing a rectal exam. People are like, oh, I don't want to do a rectal exam, that's so uncomfortable. But the woman just had a baby. So I think that a rectal exam is okay. And this way we would not miss our 3rd and 4th degree lacerations. Now, what if a patient has had a severe laceration and now they're back in your office, they're pregnant again? How should they be managed? Well, there are tons of studies, but there have been a few. They are at increased risk for another anal sphincter laceration. Now, the odds is high of a very low number. So it's still more than likely they will not have a 3rd or 4th degree laceration. But they are up to 4 times more likely to have one. Now, most women who have a 3rd or 4th degree laceration remember it, right? They remember it. They're in pain. The recovery is difficult. This is, again, a point of shared decision making. I think that patients should be talked to. You're at increased risk with a very small number, right? Now, if they never had any fecal incontinence symptoms, they had their birth, they had their 3rd or 4th, it was repaired, they had no fecal incontinence symptoms, those women were at very low risk for developing fecal incontinence after a subsequent delivery. But they were at increased risk for another laceration. If they had transient fecal incontinence, so they had their repair, they had some fecal incontinence when they're in the hospital, maybe the first 1 or 2 weeks after they got home, and then it went away, those women almost all had, or quite a few of them, almost all of them had some fecal incontinence, and some ended up having permanent fecal incontinence. Now those women who had a 3rd or 4th, developed fecal incontinence, and just have had it ever since, they almost all had deterioration of symptoms. So again, a point of shared decision making. Once you have fecal incontinence, it is not simple to get rid of it, right? It is a chronic disease. And, it's one of those diseases, like everybody thinks, heart disease is terrible, which it is, and cancer is terrible. But fecal incontinence is a real problem if you have it, right? It's a real problem if you have it. So again, I think that this is an area of shared decision making. In my experience, when we had these kinds of consults, most women had an idea about their birth plan and were undeterred by this counseling. But on the other hand, there might be a few women who really, I don't want to go through that again. We do cesarean deliveries for far less than this, in my opinion. I'm not an MFM. I'm not trying to offend any of the MFMs in the audience. Okay, so now let's move on to urinary incontinence, and because that's another thing that can happen during pregnancy and after delivery. So there is one trial, and actually this trial was running when we were one of the recruiting sites at UNM many years ago. It's a randomized trial of cesarean delivery versus vaginal delivery for breech presentation. So most of us are aware of this. It turns out it's really, really difficult to randomize women to cesarean versus vaginal birth, right? And it probably is unethical to do that, right? Because I think women should have a choice about their reproductive health, and most women aren't interested in being randomized. This trial was for breech, as we know, and the women who had a cesarean delivery did have slightly less urinary incontinence than the women who had a vaginal delivery. If they did get it, there was no difference in severity, and the difference was not sustained at 2 years. So it was a transient problem, usually went away. But if you had you were incontinent at 3 months after the delivery, it was a predictor for incontinence much later. So you had a 92% chance at 5 years that you would have symptoms. This is a landmark trial or epidemiologic study from our Scandinavian colleagues, looking at their big database of the difference in incontinence based on your parity. So 10% of these women were nulliparous, 15% had cesarean delivery, and 21% had a vaginal delivery. So the risk of that's the incidence of incontinence. Obviously, you can't, these women all delivered. So it was higher for women who had a vaginal birth. And the risk of moderate to severe UI was associated with vaginal delivery. However, age trumped. So when you got to age 50, the influence of parity on you having incontinence sort of went away. Now, what do we make of this? I mean, it's a long time, right? If you have your baby in your 20s and now you're 50, you had 25 years of having a increased risk of incontinence. And cesarean delivery was not completely protective either. So there are some elements here that we haven't quite totally sorted out. Again, this is something that we can talk to with women. Now, if more recently, Vicky Honda, she had this great idea. So the real problem with this is the exposure is at birth, and the outcome is, in your 50s, right? So it's really hard to do anything prospectively. So she said, let me recruit women who delivered 5 years earlier, right? So I'm going to recruit these women 5 to 10 years after their initial birth, and then I'm going to start following them because I'm middle-aged, and if I start following them for 20 years, I'll be dead by the time the study's done. So I'm going to recruit them 5 to 10, Vicki probably didn't say that, but 5 to 10 years after the delivery. And so they recruited this cohort of over 1,000 women, and they were able to compare the index birth is vaginal or the index birth is C-section. Now, lots of these women had more than one baby, right? So the data are a little bit messy. If you had a vaginal birth, your risk of stress incontinence was higher, but the risk of prolapse was much higher. And an operative vaginal birth, look at those odds ratios, they nearly double. So again, these data would support forceps or vacuum, operative delivery, and vaginal birth do play a role in these pelvic floor outcomes. Now, I'm a urogynecologist. I can't have a talk without some yicky prolapse picture. So this is my yicky prolapse picture. So pelvic organ prolapse. The best study that has looked at this is the Oxford Family Planning Study. So women with 2 deliveries are 8 times more likely to have a prolapse surgery, right? So that's a pretty hard outcome. So as compared to women with no deliveries, no vaginal births. So the odds ratio is pretty high. This is a real thing. As you have more vaginal births, your risk for prolapse increase. Now, all of us have seen multips with no prolapse. Grand multips, 0 prolapse. Why is that? We don't know, right? We can't personalize this. These are broad data from a large cohort. It would be great if we could say, you know, your risk, your individual risk is X, Y, and Z. So maybe it makes more sense for you to avoid these interventions or maybe have a C-section versus the gal who we think, you know, she's just not going to develop those problems. Why are we at increased risk of prolapse after vaginal birth? I think we have some data on the mechanisms. So we can now do imaging of the levator ani complex. Y'all, does everybody know what the levator ani is? Right? It's that basket of muscle that supports the pelvic floor. Now, how thick is the levator ani? Heidi, you can't say. How thick is it? Who says it's a centimeter thick? 2 centimeters thick? Go down. Half a centimeter? Half a centimeter? It's thin, right? Half a centimeter or less. You can hold it up to the light and see through it. So it is a thin muscle which is very large, right? It encompasses a big area. So it's not unbelievable that it could not rip or tear during a birth, okay? So 23%, 1 in 4 of births end up with some levator ani imaging, a levator ani problem. So again, I'm not going to use that weird pointer. So this is an MRI. This is an MRI. This is the vagina. So there's a probe in the vagina. Here's the urethra. Here's the rectum. And you can see these muscles on either side. And conveniently, the way I like to read MRIs, there are arrows pointing to the defect. So these are real. You can see the difference between this nice U-shape, right? U-shape, where it's attached to the symphysis, versus this sort of sagging side, right? Not attached to the symphysis. So levator ani injury after birth. This is a large cohort from a Dutch group. No levator ani avulsion was found after cesarean section. That makes sense, right? Why would the levator ani fall apart at birth? Avulsion in this group was also about 1 in 5 to 1 in 4. The risk factors, well, were anal sphincter injuries. Well, do you think the anal sphincter injury caused the levator ani injury? Probably not, right? Probably not. Probably that whatever happened affected both the levator ani and the anal sphincter. Prolonged second stage, and our favorite risk factor for Forceps delivery. So let's talk about sexual function. How many of your pregnant women had sex? Huh? The vast majority? What year are you? I'm sorry? IVF. So people who have IVF don't have sex? I think they still have sex. So this is a cohort, almost 100% of whom are sexually active. Do your patients care about sex? Yeah? How much time do you spend talking to them about sex? 3 minutes? Do all of you talk to your patients about sex during pregnancy and after pregnancy? Do you think your patients are thinking about it? Probably. We do a terrible job here. We do a terrible job. How about gynecologic surgery? You know, I'm gonna peel off all the skin of your vagina, put a mesh in, put other sutures in. Do you spend time talking to them about sex? Yeah? My guess is we do a terrible job everywhere, not just here in Wisconsin, although this gentleman here, I'm a little worried about him. So almost half, and so what do we tell our women? What do we tell women after delivery? Don't have sex for what? Why 6 weeks? I'm sorry? Why 6 weeks? We made it up. We have no idea about any of this. This is all made up. And most of our patients don't wait 5 to 6 weeks. Almost all of them. And then we say, oh, you're not following instructions. That's why you got whatever. These patients are sexually active. They have a lot of concerns and fears about sexual activity. They have a lot of misinformation, sort of like our episiotomy information. So it's worthwhile talking to patients about it. If you're breastfeeding, you may have decreased lubrication. You might want to use a lubricant, even if you haven't done that before. If you're breastfeeding, you may experience symptoms similar to orgasm. That's not weird or you're not crazy. It's normal because you're releasing oxytocin. Lots of women report pain with sexual intercourse after delivery. That is not uncommon, particularly if you've had a laceration. We already talked about that most women have lacerations, so we should talk about it. And we do a bad job, and it's not just here in the US. There's lots of data everywhere. So let's talk about dyspareunia. Now, if you don't have pain, does that mean that you're having great sex? I'm picking on you, seem pretty resilient. No! Absence of pain does not mean you're having great sex, but that's how we as obstetricians, gynecologists measure sex, right? It's great sex if it's not painful. No. However, pain is important, right? Most people don't like it. And with lacerations, 1 in 5 women, or even with vaginal birth, 1 in 5 women will report some pain up to 6 months after their delivery. It is 80% more likely with a second-degree laceration and 270% more likely with a third or fourth. So this is something we should talk to women about. If you have pain, please let us know. Because if you have pain, what happens? You avoid sexual activity, or you have sexual activity despite pain, and then you develop other problems like levator ani spasm, et cetera, et cetera, et cetera. It causes relationship problems. So and also the fact that, sex is fun, and we don't want to keep our patients from having fun. So talk to them. Even a few words can make a difference. So how do we prevent all these problems? Well, what are the modifiable risk factors that we can get to with delivery? We can talk about the type of pushing. There's some studies looking at that. We can talk about being careful about using forceps and vacuum, episiotomy, epidural and oxytocin use, and mode of delivery. Those are the things that we can change with delivery. We can't change everything, right? We don't want people to stop getting pregnant. That's not good. And we don't want everybody to have a cesarean delivery. I am actually a urogynecologist in support of vaginal birth. So we know that midline episiotomy and forceps are bad culprits. So I think that at very least, this needs to be shared decision-making with our patients, right? The data are really very clear. Forceps increase trauma to the pelvic floor. And there are, these are a little bit old data, but there has been an increase in cesarean delivery and a decrease in VBAC. That's not good, right? I don't think that everybody should be delivered by cesarean. However, we should have discussions with our patients about what the outcomes. And some of these deliveries are on maternal request. And a lot of these requests, I think, are really ill-informed, right? People think, oh, if I don't have a cesarean delivery, my vagina is just going to fall out. Well, that's not true. Or I'm just going to have incontinence. We need to be able to give women more personalized risk calculators so that they can know their own personal risk. It, to my knowledge, does not exist yet. It should exist, right? Cesarean delivery is the most common operation in the United States. Birth is one of the major reasons to be hospitalized. We have lots of data. We should be able to figure this out. So all this gentleman here in the front row, that is what he's going to do in his career. So I look forward to reading that. Okay. ACOG says it's an ethical opinion recommending acceptance of patient autonomy. Thank God, right? Reproductive choice, right? This is part of reproductive choice. And giving women informed consent. FIGO and ACNM opposed due to the lack of data. And I think that we don't have all the data. I'm not saying we should promote cesarean delivery. Again, urogynecologists in favor of vaginal birth, but we need to engage in this dialogue with our patients. Now, what other things can we do to prevent lacerations? Antenatal perineal massage. So, I'm really interested in how you counsel your patients about antenatal perineal massage. You don't? Okay, so 4 randomized trials, 2,500 women, as little as 1 to 2 times a week, from 35 weeks. And if you Google this, you get a lot of really bizarre pictures. So maybe not in the library. Less likely to have trauma that requires suturing, less likely to report perineal pain at 3 months. Now, whether it's the massage or people learning how to relax their pelvic floor or what it is, but this is a relatively simple intervention that may improve outcomes. So to me, the cost of this is low and the possible benefit is relatively high. So, perineal massage. Okay, hand maneuvers of clinician. Lots of studies have looked at this. 8 randomized trial, 11,000 women. The outcome was usually 3rd or 4th degree tear. Warm compresses reduce. I'm seeing nodding heads. So then compresses are okay, massage no. So warm compresses reduce, massage versus hands-off reduce. So again, that perineal massage. Now, let's be reasonable with the massage. This is not massage, right? Massage is gentle pressure, right? Like this, like trying to make the opening bigger. No. Hands-off or poise versus hands-on, no effect. So whether you had your hands on or off didn't impact. Hands-off reduce the risk of episiotomy. So that's good, right? So if you keep your hands away, you're not going to cut an episiotomy. So massage, warm compresses, makes sense. Why not? Are these high-cost interventions? No, right? Now, I'm going to get into some stuff that's emerging from the group in England. So there, the NICE guidelines, so the UK publishes green top recommendations. Have you guys ever looked at those? You should pull them up, right? So they're fabulous with the National Health Service. They do systematic reviews and they publish recommendations that are to be followed throughout the country. And the green top recommendation for perineal care includes antenatal perineal massage, manual perineal protection, and cutting episiotomies at a 60 degree to the midline at the time of crowning. So there is a growing thought that medial lateral, which is the preferred method if you are going to cut an episiotomy, that does not result in more pain, difficult. It's difficult because you've never done it, right? Everything's easier once you know how, right? So not necessarily more difficult to repair, does not result in increased blood loss. And they've designed these scissors, they're epi-cut 60-degree scissors, to help people cut that angle because they think that's the angle that will protect the anal sphincter. And there is some epidemiological data that's coming out that shows that this is probably true, okay? So if you're going to cut, maybe you should get some of these weird-looking scissors. See, there's this this little metal thing that comes down and hangs in front of the anus. So you know that you're at 60 degrees. And maybe this will make a difference. I don't know. But it's interesting. So when they did, this is some of the first data that's coming out of this. This is a quality improvement paper out of the UK with 2,500 deliveries at a number of institutions. The episiotomy rates were high. Look at what they were before they instituted this, 41%. Now, I do not think that we should go back to cutting 41% episiotomies. There's still places in the world where everybody gets an episiotomy. So I don't think that we should go to that. The operative vaginal delivery was also high, 35 to 38%, right? That seems really high to me. And they decreased their OASIS incidence after implementation of the protocol. So is it applicable to a population of women who are exposed to low rates of relatively low rates of operative delivery and episiotomy? I don't know. But again, it emphasizes that there's a lot of variety in how we approach these problems. Now, what about Kegel exercises? Everybody Kegel once, just in memory, Dr. Kegel. Are you doing it? Dr. Sardo, you're Kegling? Good, excellent. 38 trials, 10,000 women. It does help reduce incontinence during pregnancy, and it does help reduce incontinence postpartum. No proved benefit for fecal incontinence. However, is it a high-risk intervention? You know, it could be kind of like a mindfulness thing, right? Maybe we could pitch it that way. So it improves your brain and improves your pelvic floor. But it's a great intervention, not hard to do. It doesn't take a long time to coach people and may change outcomes. So, in conclusion, perineal lacerations are common. Anal sphincter laceration is increased with forceps and episiotomy. Examine lacerations thoroughly. What kind of episiotomy should we cut? Unilateral. And what else should we all do? We should massage our perineums as much as possible. Thank you very much for your time. I probably went over, yes.
Wonderful talk. Thank you very much. I have a question about repair of third and fourth degree laceration. OR or bedside?
I think you should repair any severe injury in an environment where you can see, you have the proper assistance, you have good visualization, and you have the equipment you need. So if you can achieve that in a delivery room, why not? I think it's best not to move the patient. There are a lot of things going on right after birth, right? We want mom to have the baby on the skin. We want mom to initiate breastfeeding as soon as possible. That is the most important thing. The second thing is, the most important thing is mom's safety and baby safety. Then bonding, breastfeeding, all of that stuff. And so if we can do it in the delivery room, we should. I think that one way to approach this is to have a pack, a perineal laceration repair pack for third and fourth degree lacerations. So you're not sitting there going, I need an Alice. I need some delayed absorbable suture. I need the Gelpi retractor. You know, I mean, I've been there, right? And people are running around and going through the bins and whatever. So making a delivery pack for third and fourth degree lacerations makes sense to me, so you can keep it in the delivery room. And then when you do have a third or fourth, somebody coming in and helping you, right? Right? So that would be my preference. Yes, ma'am?
Are you aware of certain simulation models or tools that are more useful than others for OASIS repairs? Have we done some with like Calcom, different options, and I'm sure if you have one you recommend?
So the question was about simulation models for repair, because the incidence is relatively low and most people don't get a lot of experience in doing the repairs. And they always happen at 2 o'clock in the morning. So there are a number of models, high affinity models and lower affinity models. So Sultan's group has developed a plastic model, which is expensive. I've done the turkey leg beef tongue model for many years. It's disgusting, but it is effective. And then I developed a model, or improved upon a model, which has low fidelity, which has been used within family planning training for OASIS, which includes washcloths and a candy bar, which nobody actually eats at the end, which is good. The candy bar is poop, right? So I think that the data about simulation is that low fidelity stimulation works as well as high fidelity simulation for learning skills. We like it to be high fidelity because we think it's better, but in terms of actual outcomes and performance, my understanding is that it's no different. So I like, the problem with simulations that are complicated, those beef tongues, it takes a full day of prep from somebody. I mean, it's just a lot of work. So the low fidelity simulation is very simple and doesn't take as much time, so that's the one I went with. And I never had any money, so we couldn't buy all those models. So those are the ones that I'm aware of, and I've relied on the thought that low fidelity simulation, the outcomes aren't different in performance, so I've been going with that. Yes, sir?
So, as you're talking about the simulated models, my concern has always been that we need to really be on the cadaver, because when you look at our published years in the Lancet, that most of these repairs are inadequately repaired. A lot of people don't understand anatomy down in the area. And so that, my feeling is that particularly for those of us in medical school, we should start looking at whether we do some of these. When you're talking about internal and external sphincter injury and repair, it's going to be properly back together to look at the structures anatomically in the patient to figure out how to do that from an actual person. So I think that, and I can't tell you for 100% that we put them back together, everybody's going to time, but I think that by doing beat times and everything, it's nice, but I really think we need to actually see that anatomy.
So there are folks who use pig models. I think that this is where we have an opportunity to use some teamwork, right? You have experts here in anal sphincter anatomy, and some places have had the urogynecologists come in or delay the repair, and then there is some data that you could delay repair up to 12 hours with no difference in outcome. And so having those repaired delayed, I'm not trying to give you guys some more work, but I think that that's really going to be the solution. The problem with cadavers and sort of animal labs, well, there's lots of ethical issues around animal labs. Cadavers are expensive, and it's one, I believe repetition is very important. So we have to have knowledge, we have to practice, and we have to have guidance. And to me, the guidance part is really where we, as faculty, need to work together. You do not want me delivering your baby, right? Like, I was trained well, Dr. Sardo, but I am not, well, that's not true. I haven't delivered a lot of babies in a long time. There's some things I would not do. I have to rely on the rest of my team to help me out. All right, thank you so much for your time.